I'm Dayton Opel. I'm also one of the 5 graduating chiefs. I'd first like to thank Dr. Ladd again for coming to visit us this weekend. We're honored by your presence here, so thanks for making the trip up. My research has been looking at the role of race and gender and how they impact management of humerus shaft fractures. Dr. Meeker, who couldn't be here this morning, was my PI. Also had help from Dr. Yu, and the statisticians involved in this project were Dr. Rapone and Dr. Krishnamurthy from Washington State. And this is for work that was published in the Journal of Orthopaedics. So, as a little background to the humerus shaft fracture, this correlates to the AO fracture classification of 12A, B, and C as occurring between the surgical neck of the humerus and the epicondyles. They represent 2% of all fractures. Non-operative treatment has been studied extensively with union rates as high as 95% in Sarmiento's landmark study, but also published as low as 76%. The non-operative treatment can include a sling, coaptation splint, hanging arm cast, or functional bracing. I'll describe to you what functional bracing is on the next slide. However, there are risks associated with non-operative management, including non-union or delayed union or malunion, problems relating to the immobilization like skin breakdown, cellulitis, prolonged pain, functional limitations, and patient aversion to the non-operative treatment. Operative treatment can include external fixation, open induction internal fixation with a plate, or using an intramedullary nail. The benefit of operative treatment is that this can allow immediate weight bearing through that extremity. However, there are risks and negatives associated with operative care, including cost, infection, radial nerve injury or other iatrogenic injury, shoulder impingement from intramedullary nailing, and non-union. The indications for surgical management of humerus shaft fractures have been studied, and for my project, I specifically focused on the indication of polytrauma. Polytrauma is often cited as an indication for surgery. However, that definition of polytrauma has never been really specifically elucidated in the literature. Furthermore, there are advocates in the polytrauma population for surgical management, and there are advocates for non-operative management in the polytrauma patient. Some reasoning behind wanting to fix these patients in the polytraumatized setting is that for patients with head or chest, thorax, abdominal trauma, fixing them and having an internal fixation as opposed to a bulky splint or brace can allow for better respiration, easier nursing care, easier access to the chest, and less concern about positioning the arm. It's often cited that a patient's impaired ability to ambulate or participate in rehab is a strong driving force to allow them to fix their humerus and allow them to weight bear through that extremity. It has been shown that patients who do have their humerus shaft fracture fixed have an improved rehabilitation potential and a decreased length of stay in the hospital. Outside of the indication of polytrauma, some of the more concrete indications or absolute indications to fix these fractures include an ipsilateral forearm fracture, which would constitute a floating elbow injury, or bilateral humerus fractures, pathologic fractures, fractures with vascular compromise, grade 2 or 3 open fractures, segmental humerus fractures, fractures where the body habitus of the patient would make non-operative treatment very difficult, including patients who are very obese or have large breasts, any other condition that would make the ability to obtain appropriate alignment difficult or impossible. Other indications include a progressively worsening neurologic deficit or a brachial plexopathy, and then, of course, failure of non-operative management or a fracture that has gone on to a non-union. Pictured in the lower right is a functional brace or a Sarmiento brace, which is typically applied after a short period of initial splinting, typically in an outpatient setting. Disparities amongst patients and in our healthcare system have been widely studied and shown to exist both in relation to race, gender, and insurance status. Some very brief examples include the stage and your survival rates in cancer diagnoses are affected by the presence of if you have insurance or not. The risk of death from end-stage renal disease is affected by some of these race and gender disparities. In hospital mortality after lung cancer surgery is affected by or is influenced by your race. Rates of total shoulder and total knee arthroplasty on an elective basis have been shown to be fewer in non-white populations. Even medical student representation in all United States geographic regions has been shown to be not representative of the racial demographics of those regions. So the purpose of this study, to summarize, a humerus shaft fracture is an injury that requires acute attention. There are multiple treatment options, and the indication to fix these fractures in the polytrauma population are vague and nebulous. So all these create a confluence of factors that are ultimately subject to potential biases in the surgical treatment team. Our purpose was to identify how race, gender, and insurance status affect the management of humerus shaft fractures in the adult trauma population. And the reason that I selected the adult trauma population was this is a population that gains access to the healthcare system via the trauma system. So it eliminates access to healthcare as a potential confounding variable, and thereby avoiding a potential treatment disparity with regards to gaining access to healthcare. The hypothesis is that Black, female, and uninsured patients have a lower odds of receiving surgery for the humerus shaft fracture. So this was a retrospective cohort study of prospectively collected data. I used the National Trauma Data Bank, which is the most comprehensive and the largest aggregation of U.S. trauma registry data. It is standardized, submitted from over 900 U.S. trauma centers of all levels of designation, OHSU being a level 1. All the data is standardized. It includes demographics of the patient, diagnoses, procedures, and outcomes from each individual trauma patient admission and their hospital course. I used years 2007 to 2012. This was because these years used ICD-9. In 2013, they transitioned to using ICD-10, which came with some growing pains. So I used those 6 years in which there were 4.1 million unique trauma admissions that the NTDB collected. It is a HIPAA-compliant database. The American College of Surgeons maintains this database for quality control. I obtained an IRB waiver from the OHSU IRB for this study. The statisticians helped. They used SPSS for the statistical analysis, and there was no external source of funding for this project. So an a priori list of treatment confounders was created. These included, of course, the demographics, which I was interested, including age, gender, race, which was self-identified by the patients, white, black, Asian, American Indian, Hawaiian, or other. ICD-9 diagnosis codes were collected, main ones being humerus shaft fracture open, humerus shaft fracture closed. Those were two separate ICD-9 codes. Both of those were grouped, looked at individually, but grouped as having a humerus shaft fracture. Additionally, I created another variable that included 9 different ICD-9 codes for hip fracture, femur shaft fracture, distal femur fracture, patella fracture, proximal tibia fracture, tibia shaft fracture, ankle fracture, and then a talus or a calcaneus fracture. So these are 9 fractures from the hip to the hind foot that I wanted to include. A patient with these fractures would, in some form or fashion, potentially have restrictions with regards to weight bearing or range of motion. So this is information that I collected to use as a surrogate for their, as a marker for polytrauma, to know that if a patient is polytraumatized with regards to a lower extremity fracture, a fracture where they would theoretically, as the prior literature would recommend, benefit from surgery for their humerus shaft, decrease their hospital length of stay, improve their ability to work with therapy and rehabilitation. This is information that I felt was crucial to know. Secondarily, the ICD-9 procedure codes were collected for the humerus shaft surgery, including open reduction internal fixation, which was the vast majority of those codes, but also including intramedullary nail, which was the second most common, external fixation, and closed reduction internal fixation. Facility factors from the trauma centers where these patients received their care were gathered, including the volume of humerus shaft fractures seen at that facility per year. The thinking was that I wanted to make sure that there was not a confounder of facilities that saw high volume versus facilities that saw a very low volume, and how that affected their how they manage these fractures. I looked at the trauma center designation, levels 1 through 4, and I looked at the region where these patients were seen. I looked at patient factors, including, and this is all data that is reported by the NTDB. Looked at whether it was a work-related injury, if there was any alcohol or drug use, the length of stay for the trauma admission, if and how long the length of the ICU stay was, insurance status, which is one of our primary outcomes. If they were insured, that included Medicaid, Medicare, Blue Cross Blue Shield, private or commercial insurance, auto insurance, workers' compensation, and then if they were uninsured or self-pay. As further markers of the polytrauma status, I looked at GCS and presentation in shock, which is defined as a systolic blood pressure less than 90. And as a quantitative surrogate of the polytrauma status, I separated the ISS into 5 categories, including mild all the way up to critical. So for results, the 6 years and 4.1 million admissions yielded 28,000 humerus shaft fractures. About 20,000 of these had complete data and therefore underwent analysis. As strict statistics go, 82% of these 20,000 were white, and 50% of the white population was male, with a median age a little bit older at 51 years, and they received an overall surgical rate of 55.6%. 18% were black, and of this black cohort, 67% were male, younger with a median age of 37, and a surgical rate of 53.5%. So that is only an absolute difference from the white to the black population of 2%, but I will further elucidate why that is significant. The primary outcomes from the logistic regression model, including all of those potential confounders from the previous slide, in addition to some other ones I didn't include for the sake of time. Black males had an odds ratio of 0.73 to receive surgery on their humerus shaft. White females, in relation to white males, had an odds ratio of 0.85, and these were both significant. There was no gender disparity that existed amongst the black population, and there was no insurance disparity. Some of the secondary outcomes of interest: negative predictors of surgery included ISS, injury severity score, that was critical or severe. So these are patients that, to give an example, ISS of 75 includes death. ISS of 40 is essentially near or expected death. So these are populations that are extremely severely injured that bringing them to the operating room or trying to fix a potentially non-operative fracture would not be in their best medical interest, and that's what this information also reflected. Some positive predictors of surgery, including, as we would all expect, an open fracture, which had an odds ratio of 1.8. This was the single strongest predictor of surgery of all the factors that we looked at, and that can help serve as a reference point to some of these other outcomes. The second strongest predictor was if the patient had one of those 9 hip to hind foot fractures. If they had one of those fractures, then their odds ratio for getting their humerus shaft fixed was 1.61. And again, this was the second strongest predictor of surgery. The odds ratio for if they found themselves in the ICU for any period of time was 1.26. This is a brief list of some of the other factors in the logistic regression that we looked at. I will just highlight quickly here that there was not a regional variance in the odds ratio to have surgery on the humerus shaft fracture. This again shows that the insurance status was not significant. The presence of a lower extremity fracture was, and these are the socio-demographic variables that were isolated, showing that amongst the white cohort, females had a 0.85 odds ratio of getting their humerus shaft fixed, and that gender disparity did not exist amongst the black cohort. And against in the male cohort, black patients had an odds ratio of 0.73 to get their humerus shaft fixed compared to their white male, the white male cohort. But that racial disparity did not exist amongst females. The limitations of this study were, of course, several. Some of them relate to the what I would say are inherent in doing a large database study like this, including that the data quality from this data bank is, of course, dependent on how well each hospital submits their data. It's not a population-based data set, so it's not representative of all United States hospitals. There is an element of selection bias that exists because the data is submitted voluntarily from the trauma centers. Trauma admissions are patients that come in under the trauma system that are not admitted, i.e. die prior to arrival. They're not reported, so that may skew the selection of reported data. And this data bank does not capture any post-discharge events. So any patients that did not receive their humerus shaft fracture surgery during their trauma admission to the hospital were not captured. And that, of course, will miss a certain amount of those fractures. There is an element of information bias. The data is submitted in a standardized way, but there may be differences in the way each hospital is collecting, interpreting, and coding the data. Missing data is subjects our analysis to bias. However, we did eliminate about 8,000 of the 28,000 fractures that did not have complete data. A big limitation is that this cohort, the adult trauma population that is admitted to the hospital under the trauma system, is a unique population. It is not the standard humerus shaft fracture population, which is sort of a community isolated injury diaphyseal humerus shaft fracture. So this, again, is not generalizable to all patients with humerus shaft fractures, rather the adults who are admitted under the trauma system. Some limitations of the study itself: the comorbidities of the patients in the data bank are very poorly reported, and of course, comorbidities are a huge factor in any surgeon's algorithm to provide or not provide surgery for an injury. Unfortunately, because they were poorly reported, they were not able to be factored into the logistic regression analysis. The age was not separated into categorical variable or not included as a continuous variable. I think this is a limitation of the study as well. Rather, all patients older than age 18 were included. And I think in hindsight, a big improvement to this paper would have been to look at age more specifically or categorically to help provide a little more information on why some of these patients were or were not getting treated surgically. The length of hospital stay and whether the patient received surgery likely influence each other. Patients who received humerus shaft fracture, as you may suspect, would potentially need to recover in the hospital a little bit longer for their post-surgical course, so that those two variables may affect each other. And then, of course, another huge downside of this database study is there was no way to capture the fracture pattern of the humerus shaft fracture, whether it was a straight transverse or comminuted or spiral or oblique. Fracture pattern and severity certainly influences a surgeon's decision-making and how to treat that fracture, and this is one element of treatment that was not able to be captured, unfortunately. So take-home points. The overall rate of surgery showed that Black patients had just a 2% overall rate. That was lower than the white patients. However, the white patient cohort had the highest percentage of either being not polytraumatized at all or being mildly polytraumatized, and that is a group that was a predictor against receiving surgery. And the Black cohort, the highest percentage of these patients were in the moderate polytrauma group and had a higher rate of lower extremity fracture, both of which are very strong predictors for surgery. So based on the other variables that were positive or negative predictors for receiving humerus shaft surgery, one would have expected, based on those data points, that the Black population would have had a higher overall rate for surgery. The race and gender disparities showed that white males were significantly at greater odds to receive surgery for their humerus shaft fracture when taking into account all of the variables, and Black females and Black males had lower odds to receive surgery than their white female, white male counterparts. The gender disparity only existed between the white patients, and that is to say that Black female and Black male patients were at equally lower odds to receive surgery than their white counterparts. Again, the insurance status of the patient did not affect whether they received surgery or not. So that's a whole lot of information and data, But what it doesn't reveal, or what it doesn't really answer, is what drives this disparity. A recent poll amongst orthopedic surgeons stated that, or found that 50% of orthopedic surgeons admitted biases towards specific groups of patients. 16% of male orthopedic surgeons and 14% of female orthopedic surgeons admitted that race was a patient factor that triggered bias for them personally. And then 11% of all orthopedic surgeons in this poll indicated that bias did affect their treatment of patients. So the burning question, I think, that this study was indicated to provide information for was, do these findings of disparity reflect a bias within the treatment team? If so, if that's the case, how do we approach that? How do we combat that? These are very complex issues that were not the scope of this research presentation or this research project, but hopefully can generate some discussion towards these questions. I want to thank Dr. Yu and Dr. Meeker, who are integral to the success of this project, as well as our statisticians, Dr. Rapone and Dr. Krishnamurthy. Dr. Fries.
So that's a very nice study, thank you. I always try and bring the research home to how it affects me in my practice. And this being Portland, we do not have a large population of African American individuals. So I was wondering, is there Hispanic status? Is that reported in the National Trauma Database?
The question that Dr. Fries had is Hispanic status listed in the National Trauma Databank? The answer is no. There is a category for race, of which white and black made up the vast majority. There was a category of ethnicity, and part of those answers were Latino, not Latino, and some Pacific Islander, and there were not enough of those patients, and that ethnicity variable was not consistently filled out. I'm guessing that there must have been a sort of an optional submission element for that particular variable. So that was unfortunately not able to be included. I would have loved to see Hispanic in the race category, which would have, I think, generated enough numbers for us to use in our analysis. The other race, the self-identified race variables of Hawaiian and Asian encompassed less than 1% of all the respondents, so those were not included in the analysis. Dr. Ladd.
Yeah, thank you, Dayton. And going through, boy, that database must have been extraordinary, so good effort. I can only imagine digging through it and extracting these things. I had a couple questions. Maybe I missed it, but was there an association of age in either group?
So I think that was a big downfall of this study. The only age data that we collected was the median age of the cohorts. And the white cohort was a little bit older at 51 years. The black cohort was a little bit younger at 37 years. So to summarize the answer to your question, we didn't include age either as a categorical variable or a continuous variable in our regression analysis. I think that affects things in two ways. One is it misses the importance of using age in the surgical team's algorithm of treating a fracture, as of course maybe somebody who's either younger or older on the extremes of age may benefit more from non-operative management. And then secondarily, We weren't able to use it as a surrogate for comorbid status. That is to say that maybe somebody who is a little bit older would tend to have a little bit higher of a comorbid status than a patient that was a little bit younger. So those were two important things that not including age in this analysis missed out on.
Okay. And so then my next question is, so you're off to Cleveland, but if you were staying here or you were a traumatologist and you were going to do the next step, because you've already published this nice piece, what would it look like? Because what are your take homes? Because what do you walk away with?
Yeah.
And what would you design the study to be to go to the next step?
The question is, what would I use this study, what would be the next steps in this study? My initial interest in studying humerus shaft fractures was in elucidating the factors in the polytrauma population that are currently used, or what the current status of their polytraumatized injuries are that are leading them to getting surgery. And so I started this project wanting to define what polytrauma meant. What are the fractures or what are the other injuries currently that are lending these patients to receive surgery for their concomitant humerus shaft fracture? And I wanted to do that because not just, there's different fields of thought in our specialty or in our profession that, the gold standard is non-operative treatment, and you ought to treat all these patients initially with non-operative treatment. And then, of course, there are surgeons that say that seems like torture. You should treat all of these patients with surgery. So I wanted to initially discover, well, what are we doing? What does the current landscape look like for these polytraumatized patients? Which are the ones that are, in fact, getting surgery today in modern day? And then once we have that information, using that information to further study and find out, okay, so these are the patients, and these are the constellation of injuries that are currently lending these patients to get surgery for their humerus shaft. Can we study these concomitant injuries in this population and discover, okay, is this patient with a concomitant femoral shaft fracture or hindfoot fracture, are they actually improving their rehab potential? Are they actually benefiting from receiving their humerus shaft fracture? So that's where this study started. I wanted to define the polytrauma more specifically and use it as a benchmark or a baseline to going forward to study what the outcomes were. And sort of once I began looking at this data and finding that, these 9 fractures from the hip to the hindfoot were very strong predictors, and they can be used as a baseline to determine if these patients are in fact benefiting going forward with getting their humerus shaft fixed. My interest turned to looking at some of these sociodemographic factors, which appeared from the data to be just as significant in whether they were receiving surgery or not.